Let's talk about some CNS infections that you are likely to come across in clinical practice and that you need to know a bit about for your DM Part 1 exam. So by the end of this presentation, you'll be able to discuss some common CNS infections that may present to the emergency department, describe the epidemiology, microbiology, and clinical features of each, discuss the management of these patients, and explain the rationale behind the diagnostic and treatment modalities used. So here's the first case, a 21-year-old university student living in a hall of residence who presents to the emergency department with fever, vomiting, and headaches, and is noted to have a non-blanching rash on his arms. If you wish, you can pause the video here and try to think about what you think this is and try to recollect whatever you know about the condition. So a lumbar puncture was done on this patient, and what it shows is an elevated protein count with low glucose, very high cell count predominated by polymorphonucleus neutrophils, and a normal blood glucose level, but you can see that the ratio of the blood to CSF glucose is less than 50%. So this is bacterial meningitis. The organism involved changes according to the age of the patient. So with neonates, we need to think about Listeria monocytogenes or group B Streptococcus. With children, Neisseria meningitis comes into play, strep pneumoniae and H. influenzae. And with adults, we see strep pneumonia, Neisseria meningitis, and H. influenzae. Bear in mind that both strep pneumoniae and H. influenzae are becoming less and less common with the effectiveness and widespread use of vaccines against these bacteria. Again, the clinical features depends on the age of the patient. So for older children and adults, they present with the classical symptoms of fever, headache, neck stiffness, and altered mental status. With infants, they may simply present with fever, irritability, sometimes floppiness or atony, and a bulging fontanelle. And with neonates, their presentation may be even more vague, with failure to thrive, poor feeding, fever, and sometimes even hypothermia. It's a clinical diagnosis, and once the condition is diagnosed, treatment should not be delayed. We tend to do blood tests to support or rule out other causes, so things such as a blood count, renal function may be important because the patient may well be dehydrated, and blood cultures for future reference, not for an initial diagnosis. Treatment will start without blood culture. Similarly, a lumbar puncture may be done, it should not delay treatment, and a need for a CT scan prior to lumbar puncture is important to consider, which we will discuss later. Case 2 is a 56-year-old alcoholic who presents to the emergency department with intermittent fever, weight loss, and vomiting for 4 weeks. On examination, he's confused with mild neck stiffness, and he also has severe occipital headache, so a slightly different presentation over a longer period of time. His CSF shows a moderately elevated protein count, low glucose, high cell count predominated by lymphocytes, and a CSF to blood glucose ratio of less than 50%. And microscopy shows these organisms. So when we think about meningitis in general, we have to differentiate between bacterial, viral, fungal, and neoplastic causes of meningitis. And the cell count, opening pressure, blood glucose, and protein levels can be very useful. CSF to blood glucose and protein levels can be very useful in making this determination. You may want to pause the video and look more closely at this slide, because this is necessary for your Part 1 exam. You need to be able to differentiate between these different types of bacteria. Bear in mind, it's not just the CSF that you're going to look at, but you're going to correlate your CSF findings with the patient's clinical presentation. So with the previous patient, we had a patient with a long history, and therefore things like tuberculosis or fungal meningitis may be more relevant than a viral or bacterial cause. When do we scan patients with headaches? So some of the red flags that would make us think about doing a CT scan on a patient with headache is the characteristic of the headache. So worst ever headache, sudden onset, getting worse despite treatment. The presence of constitutional symptoms such as fever, rash, or persistent vomiting, or signs of meningism or increased intracranial pressure. Risk factors for serious intracranial pathology, new onset of headaches at age more than 50, patients who are high positive or high risk for HIV, patients with known malignancy, and patients with bleeding disorders. All of these patients can have infectious or space-occupying lesions in the brain with minimum symptoms. Any recent history of head trauma should also be considered. A 34-year-old female patient presents to the emergency department with a one-day history of confusion. She started complaining of a headache 2 days ago and has had intermittent fever over the same period. This is her CT scan. I'm not sure if you can make out the, just highlight it here. The hypodense areas in both temporal lobes, which is quite characteristic of this condition. This is viral encephalitis, and that particular pattern that I just pointed out is pertinent to herpes simplex viral encephalitis. HSV encephalitis has a bimodal distribution. It affects children and young adults, and then it can affect older adults as well. Other viruses that cause encephalitis, such as the arboviruses, have specific geographic localizations, and they tend to be seasonal. So HSV is the big and important cause of viral encephalitis. Other viruses can cause more benign forms of viral encephalitis. These could include Epstein-Barr, herpes zoster, cytomegalovirus. We talked about the arboviruses already. Then some atypical bacteria such as Rickettsia and Mycoplasma, and some parasitic infections can cause encephalitis as well, such as Toxoplasma. Patients tend to present with a viral prodrome, diffuse or focal neurology, particularly important behavioral changes, and sometimes focal neurological deficits. There may be accompanying meningeal irritation and systemic features such as fever and constitutional symptoms. Diagnosis: we take bloods. Imaging may help, and lumbar puncture may be useful, but the same rules apply as with bacterial meningitis. Case 4 is a 45-year-old diabetic who presents to the emergency department with high fever, severe back pain and weakness of the legs, and he has severe tenderness over his lower back. And this is his MR scan showing a space-occupying lesion that is compressing the cord from in front. This is an epidural abscess. The source of the infection can be hepatogenous due to instrumentation or local spread, and the risk factors are listed on the slide. Staph aureus is a common organism involved, as are gram-negative organisms, group B strep, and in some specific cases we need to consider things like Mycobacterium tuberculosis. Patients tend to go through 4 stages, starting with back pain, which then progresses to radicular irritation, motor and sensory dysfunction, including sphincter dysfunction, and then finally paralysis. The diagnosis is really through imaging, although we will get a clue with the patient's bloods, including CRP and ESR. Treatment includes broad-spectrum antibiotics and early surgical intervention. Finally, we have a 54-year-old HIV-positive patient who is brought in following a focal seizure at home. And, of course, what we're seeing here is a ring-enhancing lesion. It's really important for us to know the causes of ring-enhancing lesions on CT brain scan, particularly as it pertains to HIV patients, but these things are seen with other patients as well. The ones highlighted are important causes of ring-enhancing lesions of the brain. So that's the end of this short lecture on CNS infections. I hope this gives you some guidance as to what you should study with regard to your Part 1 curriculum. If you have any questions, we can discuss in class. Thank you.